Welcome to this lecture in the series Trauma and Orthopaedics for the Medical Licensing Assessment. In this lecture, we're going to cover disorders of the spine. As you can see, this lecture will cover a number of topics which are in the MLA related to the spine and spinal injuries. Fortunately, you do not need to know most of these in great detail. You do need to be aware of spinal trauma. And very importantly, any seriously injured patient, so that's anybody in a road traffic accident, a fall from a height, must be assumed to have an unstable spinal injury until proven otherwise, as any movement at the level of an unstable fracture will cause further neurological deficit. The injury will be detected as you work through your primary and secondary survey, which is outlined on the side of the slide there. We're not going to go through all of this in any detail today, but you should be aware of it and probably should know about it already. You need to know that if you do identify a spinal injury or a patient with a neurological deficit, you need to do a further in-detail examination. This is going to include the sensory function in all dermatomes, the muscle power, the reflexes, and don't forget a rectal examination, which is absolutely essential. You may want to document all of this on this Asia chart, which you need to be aware of, but you certainly don't need to know the detail of for any exams. Radiological assessment starts with plain X-rays. And again, like most X-rays, you're not supposed to know this in any detail for finals, but be aware of some basic features that can help you. You need to look at the soft tissues, and there are some parameters there to be aware of. You need to look at the anterior vertebral body line, the posterior vertebral body line, and the spinous processes. The next slide will show you some of the detail on this, but again, you're not going to be examined on this at finals. Here you can see the lines that were just being talked about, as well as the soft tissue swelling in front of the vertebral body that you'll find if there's an injury. If a spinal injury is identified, then CT is invaluable for the assessment of the bony anatomy. It can also be used if there's an occult injury, as it's very sensitive to picking up the fractures, but it won't tell you about the soft tissues, and this is where the MRI comes in. It will tell you what's happening to the nerves and the ligaments. As with all orthopaedics, the treatment options can be non-operative or operative. In the case of spinal injuries, non-operative treatment is really for stable injuries, which are those which will not displace under normal physiological load, or for those patients in whom surgery is not deemed to be acceptable. And there are a number of ways of doing this. You should be aware of some of the types, but not necessarily all of the indications. You can use a hard collar, which you're probably already familiar with. Some patients with cervical spinal injuries you can place in what's called a halo or a halo jacket. And then for the lumbar injuries, you can use a lumbar corset sometimes, or what's called an extension brace, which stops you dropping into a kyphosis. Cervical traction is really only used for acute injuries. Operative management is reserved for unstable fractures. So these are ones that are deemed to have a high risk of moving, or ones in whom the treatment options that we've just seen are not going to be appropriate. Basically what happens is that the spinal cord is decompressed of any fragments, and then the segment above and the segment below are fused to the injured segment. If this is in the lumbar spine, this is quite commonly done from the back, so a posterior approach, and then cervical spine is done through either an anterior or a posterior approach, and this comes down to a degree, surgeon preference and the fracture configuration, but you don't need to worry too much about the details of this. In the next part of this talk, we're going to go through the regions of the spine and some specific spinal injury patterns. This is really to make you aware of them and make you familiar with them, but you're not likely to be examined in any great detail on them. If we start at the top with the cervical spine, we'll look at the very top with the atlas fractures. So these are either in the young traumatic injuries or in the elderly with very low energy injuries. Typically they do not present with any neurological deficit, but it's more neck pain. It's quite hard to see these on a plain x-ray just because of the bones around it and the size of the bone, and they're often picked up on a CT scan. Fortunately, most of them can be treated conservatively with immobilization. If they're unstable, you may need to use that more rigid thing that we saw, which was the halo vest, and rarely surgical stabilization. Moving down, we'll look at the odontoid peg fractures, and these are relatively common either in the younger patients with a high energy or the older patients with a simple fall, as we mentioned before. Quite often these can be picked up with an open mouth view, although sometimes you need a CT scan. And again, patients don't usually present with neurological deficit, they present with pain. These can be treated either operatively or non-operatively, depending on the patient and the location of the fracture within the bone. As you can see, there are different classification types, but you don't need to worry about the specifics of this. Less commonly, you can see dislocations of the cervical spine, and this is where there is a rotational force and the facet joints jump. They can be a single facet, so it's more a rotation, or bilateral facets, in which case there is a proper anterior jump of one vertebral level on another. And these are a spectrum of trauma with, at the one end, low risk of spinal injury, and when you're getting into the bifacet dislocations, a very high risk of spinal cord injury. They can often be picked up on a plain x-ray, but certainly a CT scan is necessary to work out where any associated fractures may be. And an MRI is essential for these because you need to see what's happening to the cord and the ligaments. Typically these require reduction very carefully, and then they're going to require stabilization because they are by definition unstable. Moving further down the spine, we'll look at the thoracolumbar burst fractures, and these typically happen at the T12L1 level, where the fairly well fixed thoracic spine with the ribs gives way to the lumbar spine, and there is the opportunity for flexion at that level. And these are car crashes with a seatbelt injury or a fall with forced flexion, and you get compression of the vertebral body. This then effectively explodes, and you can get retropulsion of bone fragments into the spinal canal. And if this is enough retropulsion, you can end up with a spinal cord injury. The patient will complain obviously of either nothing or quite significant neurological deficit and may well have other injuries. The diagnosis can be made simply on a plain x-ray. However, you're going to need a CT scan to really see what the fragments are doing, as you can see on the picture here, and often an MRI to assess the damage to the spinal cord. If they do have a neurological deficit, then surgical intervention is appropriate to decompress the spine and then stabilize it, as we saw earlier. If there's no neurological deficit, then it may be appropriate to treat this conservatively in a brace, but you have to keep an eye on them, as the vertebra can collapse further and the patient will develop a kyphosis. A particular type of lumbar injury are the chance fractures, and these are compression at the front with distraction at the back. And this way you have not only a bony injury but a ligamentous injury as well. And sometimes they can be purely ligamentous going through the vertebral disc. The problem with these is that they are very unstable. and therefore once the suspicion has been raised that there is one, you need the same investigations with a CT and an MRI, because they will then require surgical stabilisation if they're unstable. We've already mentioned neurological deficit related to spinal cord injuries, and in this next section we're just going to touch on what this means and some of the different patterns that you should be aware of. So when we talk about spinal cord injury, they can be described as complete or incomplete. So a complete injury is as you would expect, complete loss of both motor and sensory function below the level of the vertebral injury. And an incomplete, there is partial preservation, so there may be some motor function or some sensory function, and this can often be mixed and patchy just depending on what bit of the spine has been damaged. It is worth pointing out at this stage that that Asia chart that is done right at the beginning is really important, as neurology can change with time and you need that very early accurate documentation to see if there's been any recovery. As you will have heard of spinal shock, where after an injury everything shuts down. Now obviously that looks like a complete cord injury, which has a worse prognosis, whereas an incomplete cord injury has a better prognosis, but if you haven't got that early measurement in the first few hours, you don't quite know what's going on over the next few weeks, and this can be really important to the patient. So document everything very accurately at the beginning if you can. The first of the incomplete spinal cord patterns that we're going to talk about is the Brown-Séquard syndrome, and this represents an injury to one side of the spinal cord. So you just have to think about that spinal cord anatomy if you can remember it, and you'll end up with a loss of ipsilateral motor function and proprioception and contralateral loss of pain, temperature and light touch. Fortunately, the prognosis with these is relatively good, with 90% of patients regaining bowel and bladder function and they're able to walk. The next incomplete spinal cord syndrome is that of central cord syndrome. So this is an extension injury to the cervical spine, really on a background of existing degenerative change. So this tends to be seen in older patients. And the pattern is that the upper limbs are more affected than the lower limbs, and it may be that the lower limbs are spared completely. So there tends to be a flaccid paralysis of the upper limbs and a hypertonic paralysis of the lower limbs. Prognosis is fair, with about half the patients regaining lower limb function if they'd lost it. However, often the hands don't recover well, and these are difficult to treat. So you have they're expectant, they're stable fractures, you have to watch them, but often hand function is not well recovered at the end of it. The last of the incomplete spinal cord syndromes is slightly different. This is an arterial problem where the anterior artery gets compressed. So in this condition, you have preservation of light touch and proprioception, as they run in the dorsal columns, and loss of motor function, pain and temperature sensation. Unfortunately, because this is a vascular injury, the prognosis is more guarded. If they get early recovery, they're likely to do well, but if there is not early recovery, then the prognosis is poor. We'll now move on to back pain. Now this is a big topic. It does come up in the MLA, it does come up in finals, as it's something that's seen not only in hospital, but in the community. So you do need to be aware of back pain, what the differential diagnoses are, and how you might go about managing it. So broadly speaking, there are three things. There is mechanical low back pain, radiculopathy or nerve problems, and major spinal pathology. And we'll look at each of these in turn. The first one we'll look at is mechanical low back pain, and this is the most common back pain problem. So it is typically not related to any specific disease or significant injury. So if the patient describes a significant injury, then it is unlikely to be this. It's often related to degeneration, so we see it in the older patient, and it frequently presents after an incident. This is typically fairly minor, a slip or a fall or a twist or some heavy lifting, and they describe a pain which is worse with movement, eases with rest, eases with simple analgesia. There isn't any neurological symptom associated, no radiculopathy, no numbness, and typically it eases over time and with physiotherapy. What patients have to understand with this is that 90% of people will have some back pain at some point, and therefore aggressive treatment usually isn't appropriate. Typically these patients don't need lots of investigations unless the symptoms don't settle, or if there are any other red flags such as radiculopathy, change in bowel habit, loss of weight, or anything that makes you suspicious of underlying deep-seated pathology. The next thing we're going to discuss is radiculopathy. So this is nerve root pain. It's characterized by pain, paresthesia and numbness in a dermatomal distribution. The pain is often electric, shooting, or even they describe burning. And intermittently they may also have altered sensations, so there may be some numbness or some tingling. Typically there's no history of trauma, although again, like the mechanical low back pain, there may be evidence of lifting or twisting bringing it on. Classically, radiculopathy is associated either with a herniated disc or with narrowing of the exit foramen of the spine due to some degenerative change. Most of the time, conservative treatment is appropriate, physiotherapy to sort out the back movements, and things will settle down. If there is associated loss of bladder control or significant motor function loss, such as a foot drop, then this warrants further investigation. But usually radiculopathy in the early acute phase will recover. Sciatica is classically used for pain in the distribution of the sciatic nerve, so this is below the knee radiating down to the lateral aspect of the foot. It's often a bit vague for any sort of pain in the back of the leg, and therefore it should be avoided unless absolutely necessary. As we just mentioned, one of the very common causes of lumbar radiculopathy is the herniated disc, typically 20 to 50-year-olds, and we mentioned this bending, twisting injury. Most herniated discs resolve with time, so you can wait. Occasionally, steroid injections to try and reduce them are appropriate, and very occasionally, if the symptoms don't settle, then discectomy to remove whatever's causing the pressure. One other point with this you just need to be aware, because you will see MRI reports, is that herniation is a displacement of disc material. It's a bulge. It's something physical within the intervertebral space. Degeneration is just wearing out, drying out of the disc. This is often a normal feature. It doesn't mean that the patient is going to have back pain or radiculopathy. Again, this is not the sort of thing you're going to be examined on, but it's something you have to be aware of, as patients will present with MRI reports, or you will receive MRI reports which say disc degeneration. It's often a normal finding. The final point is about major spinal pathology. Now, these usually will be self-evident. These are fractures, so the patient will describe a significant fall, although bear in mind the osteoporotic patient. Infections, again, you'll pick these up with a swinging temperature, a feeling of being unwell. Classically in the spine, this is TB. Tumours, most commonly, and we'll talk about these in a minute, metastatic. There's often other presentation, which may be weight loss or other features. Or Cauda-Equina syndrome, which we talked about in the emergencies lecture, but we're going to cover briefly here. If you suspect any of these, they require an urgent referral for for further investigation and management. As we mentioned, cauda equina syndrome is covered in more detail in the emergencies lecture, and I'd refer you back to that one. But essentially, it's a compressive injury to the lumbar sacral nerve roots from a central disc herniation, and you get impairment of the bladder, bowel or sexual function and this perianal or saddle area numbness. There often is also bilateral radiculopathy, whether this is bilateral, as we mentioned, sciatica or other, is variable. This is a surgical emergency. It needs urgent investigation and urgent management. If it's left, you get permanent nerve damage, which can be permanent bladder or bowel function. So really, if you suspect it, they need an urgent referral to accident and emergency. And if you're in hospital, it needs urgent imaging and urgent surgical opinion. We've covered the broad brushstrokes of back pain. You have to be aware that there are some red flags which should raise your index of suspicion. We're just going to touch on these briefly. So these are any history of significant trauma. And we all know what that means. If the patient is very young or older, you have to think that this is abnormal. In the older patient, you're starting to worry about osteoporotic fracture or malignancy. And certainly in a patient under 20 who develops acute back pain, you have to be starting to think about malignancy. Typically, mechanical back pain is lumbar. So if they have thoracic pain or abdominal pain, there is something else going on. Again, mechanical back pain tends to go away when you're lying down, which is why patients take to their beds. So if they have night pain, again, this is suspicious. As I mentioned previously, this sort of pain gets worse with movement. So if the pain is not getting worse with movement but is constant, then you have to worry that there's something else non-mechanical driving it. If there is any history of constitutional symptoms, so fevers, weight loss, night sweats, you have to be thinking malignancy. Equally, if they have any previous history of malignancy or drug abuse, IV drug abuse, we're thinking bacteria seeding the spine from the blood. It's a possibility. You have to bear that in mind. If the range of motion doesn't get any better, they can't stretch their way out of it, you have to be suspicious. If you know there's a background of any structural spinal deformity, they've got a scoliosis, you have to be thinking about it. If they have any neurological deficit, obviously you're going to be worried, and this should be flagged up at the top. And finally, if they have any focal neurological deficit, which we've just touched on with cauda equina syndrome, any of these require an urgent referral stating these are the red flags. You will highly likely get asked about the red flags when you get to the MLA part of finals. We're now just going to touch on a couple of things which you need to be aware of, partly for the terminology, but are unlikely to be examined particularly. The first one is spondylolisthesis, which is this basically means a slip of the spine. So in this, you will see on the X-ray a displacement of one of the vertebral qualities relative to another. Typically, this is at the L5-S1 level. Most often, it's an incidental finding, just happens to be picked up on an X-ray. It may be associated with a fracture, but usually these are what's called a pars intra-articularis fracture, and these classically are stress fractures. So they can sometimes be mistaken for an acute injury. Most of the time these are chronic. Unless they're very displaced, they're stable, and they don't require urgent referrals. We'll just talk briefly about spinal infection. So this can affect the disc, the vertebra, the spinal canal, or the soft tissues surrounding the spine. So this can be a discitis, an osteomyelitis, an epidural abscess, or a psoas abscess. The symptoms can be quite severe, basically pain, and they can be prolonged. and occasionally there is neurological injury, but these are not common. The pain, although it can be quite severe, is often poorly localized, not necessarily simply back pain. They may or may not have a temperature, and because these are more abscess in nature, it's often a swinging temperature. So if you do have a patient in which you suspect this might be the case, you have to look at them for general signs of infection. So where has this come from? Is it a chest infection? Is this cardiac in origin? Think about, as we mentioned previously, IV drug abuse. Think about TB, as these are possible sources. And then in your workup, you're going to do the neurological examination, you're going to do blood cultures, imaging in form of apiolateral X-ray, but ultimately an MRI is going to pick up not only the location of any problem, but the nature of it. Is it abscess? Is there edema around it? But if you do suspect it, then you require a referral on to a spinal surgeon, because they're going to need to take some form of biopsy and investigate with infectious diseases further. The final part of this talk just covers spinal cord tumours. And again, you're not going to be expected to know these in great depth, but you need to know the principles. So like all tumours, these can be primary or secondary. So the primary ones originate within either the spine or the spinal cord. So these are meningiomas, schwannomas, or the astrocytomas, ependymomas, these sort of things. The secondary, which are far more common, they originate from cancer somewhere else in the body, metastasizing typically to bone. So these normally affect the vertebral bodies. So as you'd expect, the primary symptom is pain, typically back pain, and this is often not only worse with movement, but worse at night as well. If there is collapse of the vertebral body with retropulsion, or there is a big tumour mass, you're going to get neurological deficit. And this can be patchy, it may be numbness, maybe weakness, maybe bladder bowel dysfunction. It can be very, very variable. But more commonly it is pain rather than neurological deficit as the first presentation. So your diagnosis is relatively simple. You're going to do a full neurological examination, and then ultimately an MRI is going to tell you most about the nature of the tumour, and then probably some form of biopsy to see what it is, and then a good look, as you would do as any tumour workup, to work out if there's a primary coming from anywhere else. There are a number of treatment modalities, and these are very much dependent on both the tumour and the patient and the symptoms. So in the acute phase, steroids may be appropriate to reduce swelling and reduce pressure on the spinal cord. Surgery is quite common, particularly for the metastatic tumours, really to maintain the structural integrity of the spine and stop neurological symptoms getting any worse. So this may be debulking the tumour and then putting in a metal cage and doing a fusion, as we saw earlier on. Radiation can be used preoperatively or postoperatively or both to try to shrink the tumour down. And if the tumour is chemosensitive, then that may also be appropriate. Metastatic tumours are managed in a very similar way, which is not only treating the tumour that you see in the spine, but consider what the primary is, and often if you treat the primary, you get a better result in the spine. That brings us to the end of this talk on conditions which affect the spine and the spinal cord for the MLA. As you can see, we've covered a number of topics. Things like ankylosing spondylitis are very much more covered by the rheumatologist, so we've left that out. As you will have noted, you do not need to know a great deal of depth about most of the problems in the spinal cord and the spine, but you do need to know the broad brushstrokes and the emergencies and how to identify mechanical back pain as opposed to more significant and more urgent back pain. We hope that you found this useful, and we hope that you found the other lectures in the series useful as well.